So, very good evening, everyone. I am Dr. Satyabrata, MDDM clinical pharmacologist, and today I am going to discuss on cell cycle specificity of antineoplastic drugs. Coming to introduction, what is neoplasia? Neoplasia is characterized by a loss in the normal control mechanism that govern cell survival, proliferation, and differentiation. And tumor stem cells reside within a tumor mass have the ability to undergo repeated cycles of proliferation. These cells can migrate to distant sites, which is known as metastasis. And antineoplastic drugs prevents tumor growth and may have effect on normal cell growth. So this is a good picture showing mechanism of antineoplastic drugs. 6 purine synthesis. In every step there are some drugs inhibit the neoplasia, that is 6 mercaptopurine, 6 thioguanine inhibit purine ring biosynthesis and inhibit DNA synthesis. Purine synthesis inhibitors. Then Alimta methotrexate. Methotrexate inhibit dihydrofolate reductase, block thymidylate and purine synthesis. Methotrexate blocks purine synthesis inhibitor and also inhibit the ribonucleotides to deoxyribonucleotides pathway. And then camptothecins, etoposide, teniposide, daunorubicin, doxorubicin block topoisomerase function and inhibit the DNA synthesis. And protein tyrosine kinase inhibitors, antibodies that block activities of signaling pathways, that is enzymes. And in the right side, hydroxyurea that inhibits ribonucleotide reductase. From ribonucleotides to deoxyribonucleotides, this pathway inhibited by hydroxyurea. 5-fluorouracil inhibit thymidylate synthesis. That means it inhibits deoxyribonucleotides. And gemcitabine, citarabine, fludarabine, 2-chlorodeoxyadenosine, copharabine, these inhibits DNA synthesis, that is from deoxyribonucleotides to DNA pathway will be inhibited by gemcitabine, clofazimine, etc. Then platinum analogues, alkylating agents, mitomycin and temozolomide that inhibits forms adducts with DNA, and inhibits the DNA synthesis. Then L-asparginase, it deaminates aspargine and inhibits protein synthesis from RNA to protein. This pathway inhibited by L-asparginase. Epothiones, taxanes, vinca alkaloids, extramustin inhibit function of microtubules. From proteins to microtubules, it inhibits the function of microtubules, that is epothiones, taxanes, vinca alkaloids, extramustin. And ATRA, arsenic trioxide, histone deacetylase inhibitors, they inducers of differentiation, and they will cause more and more differentiation. In this way, these are some complex mechanism of antineoplastic drugs. Then coming to cytotoxic drugs. Cytotoxic drugs are either cell cycle non-specific or cell cycle specific. Cell cycle specific drugs act in specific phase of cell cycle CCS, acts on dividing cells, but cell cycle non-specific CCNS drugs act both on resting and dividing cells. CCS cell cycle specific drugs used in short courses pulses of treatment and allows non-cycling cells to enter the cycle. The CCS cell cycle specific drugs are generally scheduled after a course of CCNS cell cycle non-specific drugs to improve cell kill. CCS cell cycle specific drugs are more effective in hematological malignancies and drugs more effective with large growth fraction. And CCNS cell cycle non-specific drugs are used in solid tumors with small growth fraction. This is the table showing the examples of cell cycle specific and cell cycle non-specific drugs. Cell cycle effects of major classes of anti-cancer drugs. Cell cycle specific CCS agents are antimetabolites that acts on S phase. Capecitabine, for example, capecitabine, cladribine, clofarabine, cytarabine, that is also known as RAC, fludarabine, 5-fluorouracil, 5-FU, gemcitabine, 6-mercaptopurine, 6-MP, methotrexate, MTX, 6-thioguanine, 6-TG. Then another group is epipodophylotoxin, topoisomerase 2 inhibitor that acts on G1S phase. For example, etoposide. Then taxanes that acts on M phase. Albumin bound paclitaxel, docetaxel, and paclitaxel. Vinca alkaloids, these are another groups, act on M phase. For example, vinblastine, vincristin, vinorelbine. Then antimicrotubule inhibitors that act on M phase. And these are all cell cycle specific agents. Then coming to cell cycle non-specific agents, alkylating agents, that is altratamine. For example, altratamine, bendamustine, busulfan, carmustine, chlorambucil, cyclophosphamide, dacarbazine, lomustine, meclorethamine, melphalan, temozolomide, thiotepa, anthracyclines group. For example, daunorubicin, doxorubicin, epirubicin, idarubicin, mitoxantrone. Anti-tumor antibiotics, this is another group of non-cell cycle specific cell cycle non-specific agents. Anti-tumor antibiotics, for example, dactinomycin, mitomycin. Then camptothecins, topoisomerase 1 inhibitors. These are cell cycle non-specific agents, CCNS. This is a very good picture that shows the cell cycle non-specific drug, alkylating drugs, nitrosourea, anti-tumor antibodies, procarbazine, cisplatin, dacarbazine. These drugs act on this G1S, G2M. These are cell cycle non-specific drug are alkylating drugs, nitrosourea, anti-tumor antibiotics, procarbazine, cisplatin, dacarbazine. But in the cell cycle in M phase, the specific drugs, M phase specific drugs are vincristin, vinblastine, paclitaxel. That are cell cycle specific drugs. Then S phase specific self-limiting, those drugs inhibit the S phase are 6-mercaptopurine, methotrexate. And S phase specific drugs are cytosine arabinoside, hydroxyurea. One is S phase specific drug, cytosine arabinoside, hydroxyurea. Another is S phase specific self-limiting, that is 6-mercaptopurine, methotrexate. And other drugs are also on G2. Busulfan can act, and checkpoints is there in cell cycle. The cell cycle comprises of G0, G1, G2, G1S G2M, G0 G1S G2M, and in between there is checkpoints, and checkpoint inverts are also there, and G0 is the quiescent phase. Then antimetabolites. Coming to this table shows the antimetabolites clinical activity and toxicities. Like capecitabine. Capecitabine inhibits thymidylate synthase, that is TS, incorporation of FUTP into RNA resulting in alteration in RNA processing, incorporation of FDUTP into DNA resulting in inhibition of DNA synthesis and function. Clinical application of capecitabine used in breast cancer, colorectal cancer, gastroesophageal cancer, hepatocellular cancer, pancreatic cancer. There might be toxicity of like diarrhea, hand foot syndrome, myelosuppression, nausea, and vomiting. Then coming to another drug, 5-fluorouracil, that inhibits the thymidylate synthase TS, incorporation of FUTP into RNA resulting in alteration in RNA processing, incorporation of FDUTP into DNA resulting in inhibition of DNA synthesis and function. Clinical application, 5-fluorouracil can be used in case of colorectal cancer, anal cancer, breast cancer, gastroesophageal cancer, head and neck cancer, hepatocellular cancer. The toxicity to 5-fluorouracil can be nausea, mucositis, diarrhea, bone marrow depression, and neurotoxicity. Then coming to methotrexate. Methotrexate inhibits the dihydrofolate reductase DHFR, inhibits thymidylate synthase TS, inhibits de novo purine nucleotide synthesis. Clinical application of methotrexate. This can be used in case of breast cancer, head and neck cancer, osteogenic sarcoma, primary central nervous system lymphoma, non-Hodgkin's lymphoma, bladder cancer, choriocarcinoma. And the toxicities to methotrexate are mucositis, diarrhea, myelosuppression with neutropenia and thrombocytopenia. Then coming to pemetrexate. Pemetrexate inhibits the thymidylate synthase TS, DHFR, dihydrofolate reductase, and purine nucleotide synthesis. Clinical application of pemetrexate, mesothelioma, non-small cell lung cancer. Then coming to toxicity to pemetrexate, myelosuppression, skin rash, mucositis, diarrhea, fatigue, and hand-foot syndrome can occur. Then coming to cytarabine. Cytarabine inhibits DNA chain elongation, DNA synthesis and repair, inhibits ribonucleotide reductase with reduced formation of DNTPs, incorporation of cytarabine triphosphate into DNA. Clinical applications of cytarabine in case of AML, acute myeloid leukemia, ALL, acute lymphocytic leukemia, CML, chronic myeloid leukemia in blast crisis. The toxicity to cytarabine can be nausea and vomiting, myelosuppression with neutropenia and thrombocytopenia, cerebellar ataxia. Then coming to gemcitabine. Gemcitabine is another drug, inhibits DNA synthesis and repair, inhibits ribonucleotide reductase with reduced formation of DNTPs, incorporation of gemcitabine triphosphate into DNA resulting in inhibition of DNA synthesis and function. It can be used in case of pancreatic cancer, bladder cancer, breast cancer, non-small cell lung cancer, ovarian cancer, non-Hodgkin's lymphoma, soft tissue sarcoma. And the toxicities to gemcitabine are nausea, vomiting, diarrhea, myelosuppression. Then coming to fludarabine. Fludarabine inhibits DNA synthesis and repair, inhibits ribonucleotide reductase, incorporation of fludarabine triphosphate into DNA, induction of apoptosis. And fludarabine can be used in case of non-Hodgkin's lymphoma, CL, chronic lymphocytic leukemia. And the toxicity to fludarabine are myelosuppression, immunosuppression, fever, myalgias, arthralgias. Then coming to cladribine. Cladribine inhibits DNA synthesis and repair, inhibits ribonucleotide reductase, incorporation of cladribine triphosphate into DNA, induction of apoptosis. Then cladribine can be used in case of hairy cell leukemia, CLL, chronic lymphocytic leukemia, then non-Hodgkin's lymphoma. Then the toxicity to cladribine are myelosuppression, nausea and vomiting, and immunosuppression. Then coming 6-mercaptopurine. 6-mercaptopurine inhibits de novo purine nucleotide synthesis, incorporation of triphosphate into RNA, incorporation of triphosphate into DNA. 6-mercaptopurine can be used in case of AML, acute myeloid leukemia. Then the toxicity to 6-mercaptopurine are myelosuppression, immunosuppression, and hepatotoxicity. Then 6-thioguanine, same mechanism as 6-mercaptopurine, and 6-thioguanine can be used in case of ALL, acute lymphoblastic leukemia, AML, acute myeloid leukemia, and the toxicity are same as 6-mercaptopurine, that is myelosuppression, immunosuppression, and hepatotoxicity. ALL, acute lymphoblastic leukemia, AML, acute myelogenous leukemia, CLL, chronic lymphocytic leukemia, CML, chronic myelogenous leukemia, DHFA, dihydrofolate, DNTP, deoxyribonucleotide triphosphate, FDUTP, 5-fluorodeoxyuridine 5-triphosphate, FUTP, 5-fluorouridine 5-triphosphate, TS-thymidine synthase. Then coming to natural product cancer chemotherapy drugs, clinical activity and toxicities. Bleomycin, oxygen free radicals bind to DNA, causing single and double strand DNA breaks mechanism. And clinical application, it can be used in case of Hodgkin's and non-Hodgkin's lymphoma, germ cell cancer, head and neck cancer. Acute toxicity of bleomycin, allergic reactions, fever, hypotension. Delayed toxicity to bleomycin, skin toxicity, pulmonary fibrosis, mucositis, and alopecia. Then docetaxel mechanism action inhibits mitosis. Clinical application, it can be used in case of breast cancer, non-small cell lung cancer, prostate cancer, gastric cancer, head and neck cancer, ovarian cancer, bladder cancer. And acute toxicity to docetaxel is hypersensitivity. Delayed toxicity to docetaxel is neurotoxicity, fluid retention, myelosuppression with neutropenia. Then coming to paclitaxel mechanism action inhibits mitosis. Then clinical application of paclitaxel, breast cancer can be used in case of breast cancer, non-small cell lung cancer, small cell lung cancer, ovarian cancer, gastroesophageal cancer, prostate cancer, bladder cancer, head and neck cancer. And acute toxicity to paclitaxel are nausea, vomiting, hypotension, arrhythmia, and hypersensitivity. Delayed toxicity to paclitaxel are myelosuppression, peripheral sensory neuropathy. Then coming to etoposide inhibits topoisomerase 2, and it can be used in case of non-small cell and small cell lung cancer, non-Hodgkin's lymphoma, gastric cancer. The acute toxicities are nausea, vomiting, hypotension, and delayed toxicities to etoposide are alopecia, myelosuppression. Then coming to vinblastine, it inhibits mitosis. It can be used in case of Hodgkin's and non-Hodgkin's lymphoma, germ cell cancer, breast cancer, Kaposi sarcoma. Acute toxicities to vinblastine are nausea and vomiting. The delayed toxicities to vinblastine are myelosuppression, mucositis, alopecia, syndrome of inappropriate secretion of antidiuretic hormone, SIADH, vascular events. Then coming to vincristin inhibits mitosis, and it can be used in case of ALL, acute lymphoblastic leukemia, Hodgkin's and non-Hodgkin's lymphoma, rhabdomyosarcoma, and neuroblastoma, Wilms tumor. And the acute toxicity of vincristin known, and delayed toxicity to vincristin are neurotoxicity with peripheral neuropathy, paralytic ileus, myelosuppression, alopecia, SIADH, syndrome of inappropriate ADH, antidiuretic hormone. Vinorelbine inhibits the mitosis. It can be used in non-small cell lung cancer, breast cancer, ovarian cancer. The acute toxicity to vinorelbine are nausea and vomiting, and the delayed toxicity to vinorelbine are myelosuppression, constipation, SIADH, syndrome of inappropriate antidiuretic hormone. Then coming to individual drug, methotrexate. Methotrexate is a folic acid analog that binds with high affinity to active catalytic site of dihydrofolate reductase DHFR, results in inhibition of synthesis of THF, tetrahydrofolate, the key 1-carbon carrier for enzymatic processes involved in de novo synthesis of dimethylate, purine nucleotides, amino acid serine, and methionine, and intracellular formation of polyglutamate metabolites with addition of up to 5 to 7 glutamate residues is critically important for therapeutic action of methotrexate MTX, and this process is catalyzed by the enzyme polyglutamate synthase that is FPGS. Then why resistance to methotrexate has been attributed? The resistance to methotrexate MTS has been attributed to decreased drug transport via reduced folate carrier or folate receptor protein, decreased formation of cytotoxic methotrexate MTX polyglutamates, increased levels of the target enzyme DHFR dihydrofolate reductase through gene amplification and other genetic mechanisms, and altered DHFR dihydrofolate reductase protein with reduced affinity for MTS methotrexate. Recent studies have suggested that decreased accumulation of drug through activation of the multi-drug resistance transporter P170 glycoprotein may also result in drug resistance. MTS methotrexate can be administered by intravenous, intrathecal, or oral route. Renal excretion is the main route of elimination and is mediated by glomerular filtration and tubular secretion. Hence, dose modification in renal dysfunction needed. Care must be taken when MTS methotrexate is used in presence of drugs such as aspirin, non-steroidal anti-inflammatory agents, and penicillin and cephalosporins, as these agents inhibit the renal excretion of MTS methotrexate. The biologic effects of MTS methotrexate can be reversed by administration of the reduced folate leucovorin 5-formyl tetrahydrofolate or by L-leucovorin, which is the active enantiomer. Leucovorin rescue is used in conjunction with high-dose MTS methotrexate therapy to rescue normal cells from undue toxicity, and it also used in cases of accidental drug overdose. Then coming to 5-fluorouracil. 5-fluorouracil is inactive in its parent form, and it requires activation via a complex series of enzymatic reactions to ribosyl and deoxyribosyl nucleotide metabolites. One of these metabolites, 5-fluoro-2-deoxyuridine 5-monophosphate FDUMP, forms a covalently bound ternary complex with the enzyme thymidylate synthase and reduced folate 5,10-methylene tetrahydrofolate, a reaction critical for the de novo synthesis of thymidylate. This results in inhibition of DNA synthesis through thymine-less death. 5-fluorouracil converted to 5-fluorouridine 5-triphosphate FUTP, which is then incorporated into RNA, where it interferes with RNA processing and mRNA translation. Then 5-fluorouracil converted to 5-fluorodeoxyuridine 5-triphosphate FDUTP, which can be incorporated into cellular DNA, resulting in inhibition of DNA synthesis and function. Thus, the cytotoxicity of 5-fluorouracil by its combined effects on both DNA and RNA mediated events. Then 5-fluorouracil administered intravenously, and the clinical activity of this drug is highly schedule dependent. Because of its extremely short half-life, on the order of 10 to 15 minutes, infusional schedules of administration have been generally favored over bolus schedules. Up to 80 to 85% of an administered dose of 5-fluorouracil 5-FU is catabolized by the enzyme dihydropyridine dehydrogenase (DPD), a pharmacogenetic syndrome involving partial or complete deficiency of the DPD dihydropyrimidine dehydrogenase enzyme seen in up to 5% of cancer patients. Hence, severe toxicity in the form of myelosuppression, diarrhea, nausea, and vomiting, and neurotoxicity is observed. Then 5-FU remains the most widely used agent in the treatment of colorectal cancer, both as adjuvant therapy and for advanced disease. The activity against a wide variety of solid tumors, including cancers of the breast, stomach, pancreas, esophagus, liver, head and neck, and anus. Major toxicities include myelosuppression, gastrointestinal toxicity in form of mucositis and diarrhea, skin toxicity manifested by hand-foot syndrome, and neurotoxicity. Then coming to 6-mercaptopurine. 6-mercaptopurine 6-MP was the first of the thiopurine analogs found to be effective in cancer therapy. This agent is used primarily in treatment of childhood acute leukemia. 6-mercaptopurine 6-MP is inactive in its parent form and metabolized by hypoxanthine guanine phosphoribosyl transferase (HGPRT) to form the monophosphate nucleotide 6-thioinosine inosinic acid, which is in turn inhibits several enzymes of de novo purine nucleotide synthesis. Then monophosphate form metabolized to triphosphate form, which can be incorporated into both RNA and DNA. Then significant levels of thioguanilic acid and 6-methyl mercaptopurine ribotide MMPR are also formed from 6-MP, 6-mercaptopurine. These metabolites may contribute to its cytotoxic action. Then 6-MP, 6-mercaptopurine is converted to an inactive metabolite 6-thiouric acid by an oxidation reaction catalyzed by xanthine oxidase, whereas 6-thioguanine undergoes deamination. This is an important issue because purine analog allopurinol, a potent xanthine oxidase inhibitor, is frequently used as a supportive care measure in the treatment of acute leukemias to prevent the development of hyperuricemia that often occurs with tumor cell lysis. Simultaneous therapy with allopurinol and 6-mercaptopurine 6-MP result in increased levels of 6-MP 6-mercaptopurine, thereby leading to excessive toxicity, which is not seen with thioguanine. Then coming vinblastine, an alkaloid derived from the periwinkle plant Vinca rosea. Mechanism of action involves inhibition of tubulin polymerization, which disrupts assembly of microtubules. An important part of cytoskeleton and mitotic spindle. This inhibitory effect results in mitotic arrest in metaphase, bringing cell division to a halt, which then leads to cell death. Vinblastine and other Vinca alkaloids are metabolized by the liver P450 system, and majority of the drug is excreted in feces via hepatobiliary system. Hence, dose modification required in liver dysfunction. Adverse drug reactions include nausea and vomiting, bone marrow suppression, and alopecia. Potent vesicant, and care must be taken in its administration. Effective in treatment of Hodgkin's and non-Hodgkin's lymphomas, breast cancer, and germ cell cancer. Then vincristine. Vincristine is another alkaloid derivative of Vinca rosea and is closely related in structure to vinblastine. Mechanism of action, mechanism of resistance, and clinical pharmacology are identical to those of vinblastine. Then vincristine effectively combined with prednisone for remission induction in acute lymphoblastic leukemia in children. Then effective in various hematologic malignancies such as Hodgkin's and non-Hodgkin's lymphomas and multiple myeloma, and in several pediatric tumors including rhabdomyosarcoma, neuroblastoma, Ewing's sarcoma, and Wilms tumor. The main dose limiting toxicity is neurotoxicity, usually expressed as a peripheral sensory neuropathy. Autonomic nervous system dysfunction with orthostatic hypotension, urinary retention, and paralytic ileus or constipation, cranial nerve palsies, ataxia, seizures, and coma have been observed. Myelosuppression less significant than vinblastine. Then coming to paclitaxel. Paclitaxel and an alkaloid ester derived from Pacific yew, Taxus brevifolia, and European yew, Taxus baccata. The drug functions as a mitotic spindle poison through high affinity binding to microtubules with enhancement of tubulin polymerization. This promotion of microtubule assembly occurs in absence of microtubule associated proteins and guanosine triphosphate and results in inhibition of mitosis and cell division. Paclitaxel has significant activity in solid tumors including ovarian, advanced breast, non-small cell and small cell lung, head and neck, esophageal, prostate and bladder cancers, and AIDS related Kaposi sarcoma, according to syndrome related Kaposi sarcoma. And it is metabolized extensively by liver P450 system, and nearly 80% of the drug is excreted in feces via hepatobiliary route. Dose reduction is required in patients with liver dysfunction. Then hypersensitivity reaction may be observed in up to 5% of patients. A novel albumin-bound paclitaxel formulation, Abraxane, is approved for use in metastatic breast cancer. And in contrast to paclitaxel, this formulation is not associated with hypersensitivity reactions, and pre-medication to prevent such reactions is not required. Moreover, abraxane significantly reduced myelosuppressive effects compared with paclitaxel, and the neurotoxicity that results appears to be more readily reversible than observed with paclitaxel. Then coming to docetaxel. Docetaxel is a semi-synthetic taxane derived from the European yew tree. Mechanism of action, metabolism, and elimination are identical to those of paclitaxel and approved for use as second-line therapy in advanced breast cancer and non-small cell lung cancer. And docetaxel major activity in head and neck cancer, small cell lung cancer, gastric cancer, advanced platinum refractory ovarian cancer, and bladder cancer. Then coming to epipodophylotoxin. Etoposide is a semi-synthetic derivative of podophylotoxin which is extracted from maple root Podophyllum peltatum, and intravenous and oral formulations of etoposide are approved for clinical use in the USA, United States of America. The oral viability is about 50% requiring oral dose to be twice that of an intravenous dose. Up to 30 to 50% of drug is excreted in the urine, and dose reduction is required in renal dysfunction. Main site of action is inhibition of DNA enzyme topoisomerase 2. Etoposide has clinical activity in germ cell cancer, small cell and non-small cell lung cancer, Hodgkin's and non-Hodgkin's lymphomas, and gastric cancer. Effective in high dose regimens in the transplant setting for breast cancer and lymphomas. Then coming to bleomycin. Bleomycin is small peptide that contains a DNA binding region and an iron binding domain at opposite ends of the molecule. Mechanism action MOA by binding to DNA, ribonucleic acid, which results in single and double strand breaks following free radical formation and inhibition of DNA biosynthesis. The fragmentation of DNA is due to oxidation of a DNA bleomycin Fe2 complex and leads to chromosomal aberrations. Bleomycin is a cell cycle specific drug that causes accumulation of cells in G2 phase of cell cycle. Bleomycin is indicated for treatment of Hodgkin's and non-Hodgkin's lymphoma, germ cell tumor, head and neck cancer, and squamous cell cancer of the skin, cervix, and vulva. Advantage of it is given subcutaneously and intramuscularly or intravenous. It can be given subcutaneous, intramuscular, or intravenously. And elimination of bleomycin is mainly via renal excretion, and dose modification is recommended in patients with renal dysfunction. And pulmonary toxicity is dose limiting for bleomycin and usually presents as pneumonitis with cough, dyspnea, dry inspiratory crackles on physical examination, and infiltrates on chest X-ray. Thank you very much for watching my videos and sharing, subscribing, and liking my videos. So please subscribe, like, and share my videos, and watch all the videos completely till the end of the video, and learn more and more about different diseases and different drugs used to treat the diseases, and also some research oriented topics. And if you want to learn more and more, then you can go through different original articles and case series, case report, meta-analysis, systematic review, and other articles, and also from good journals, and also from guidelines of different disease management. You can read and learn more and help others and help yourself. Okay, this is for today's session, and we will meet again on another session next day. Thank you very much. Jai Jagannath.